You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 7th, 2025. This week, I'll be discussing some listener feedback on non-culprit PCI in patients with STEMI, a major cardiac result in patients with chronic kidney disease on hemodialysis, some news on GLP-1 agonists, a dubious stroke trial, and an AHA preview. So I received some pretty harsh feedback on my coverage last week of the non-significant iModern trial of FFR-guided non-culprit PCI at the time of STEMI. In my discussion, I made the case that the non-significant results were entirely consistent with the mountain of evidence that PCI does not reduce outcomes in patients with stable disease over medical therapy. What did not make sense to me was this guideline support of non-culprit PCI at the time of STEMI. Why would PCI of a stable lesion over medical therapy alone not improve outcomes in every setting except STEMI? So an RCA total occlusion in an inferior MI, it coexists with an LAD lesion. It means that the RCA lesion is the acute lesion and the LAD is the chronic lesion. How could PCI of that LAD improve outcomes when no other trial of stable lesions has shown benefit to PCI over medical therapy? Now, iModern trial found no benefit for doing the complete versus culprit-only revascularization. And when I discussed the trial last week, I supported my thesis by appraising the PRIMULTI trial, the complete and full revasc trials. Now, the PRIMULTI trial was underpowered. The complete trial was positive, but it was driven only by an MI reduction, and of course it's very difficult to measure peri-procedural MIs at the time of a STEMI. And full revasc was a negative trial. So an academic interventional cardiologist wrote to me, quote, "It is unclear why you write off the results of complete, which is by far the largest and most definitive trial in the space with 4,000 patients. The composite hard endpoint of death or MI was reduced, and this signal continued to diverge over the course of follow-up. The comment about peri-procedural MI to discount the results would seem irrelevant." This is what this person wrote to me. Well, my response to that comment is I disagree. Over and over again, peri-procedural MI seems very relevant in COURAGE and, of course, in the EXCEL trial. Also, I would ask my colleagues, since complete is so definitive and large with its 4,000 patients, why didn't such a profound reduction in MI also reduce CV or all-cause death? That it didn't do that makes me wonder about A, the importance of MI reduction as an outcome, and here I would cite David Brown's paper on surrogacy in CV trials that's published in JAMA Internal Medicine, and I'll link to it. And B, perhaps peri-procedural MI is more important than my listener thinks. Now, this listener didn't just criticize my thoughts on complete. The second criticism that this person had was that I missed two important trials in this space. I missed Compare Acute and Dynami 3 Culprit. These trials, he writes, show lower composite endpoints with complete revascularization. Now, I went back and looked. Compare Acute had small numbers of events. It was driven mostly by revascularization in the non-culprit PCI group, and it was unblinded. So, of course, unplanned revascularization is going to be higher if you know that the patient has a lesion that's left untreated. And it's similar to Dynami 3. This was another small trial with few endpoints, and it was totally driven by revascularization, which is, of course, biased by the open-label nature, so I excluded those trials in my discussion. Finally, my colleague objected to my comment that I felt that culprit shock should have been included in meta-analyses of culprit-only versus complete revascularization. I feel this way because culprit shock asks the same question, culprit-only versus complete revascularization in patients with STEMI. Now, this group had cardiogenic shock, but you would think that full revascularization could help in cardiogenic shock. My colleague disagreed, and he cited two aspects of the trial. One were the results, and the other problem was with the protocol, namely that it included doing chronic total occlusions. So my listener made the point that there was much higher rate of renal replacement therapy in the complete arm, and looking at the results, it was primarily driven by this. And he also wrote, I can't imagine any interventionalist in their right mind trying to open up a CTO, non-infarct, complex bifurcation in a shock patient. But that's what the study protocol mandated. Now, my response is I disagree again. Both components of the primary endpoint, death and RRT, were statistically lower in the culprit-only group or higher in the complete arm. So it wasn't just RRT, renal replacement therapy, it was also death. And yes, CTO was included in the protocol, which is probably unwise, but these were present in only 22% of both groups. So the argument that trial procedures drove the negative result for complete revascularization does not hold water to me. But I say thank you again for listening and this robust comment. Now I'll mention a second listener. Here, this is Adrian Lonesco from Wales. I have never known anyone from Wales, so thank you for writing, Adrian. His message that I was biased against stents was couched in kinder words and a kinder tone. He wrote that we use stenosis severity to guide PCI, and because of the partial overlap of diameter reduction with instability of the plaque, we stent, by chance, some unstable lesions. We also use FFR and IFR, and again, by chance, we stent some unstable lesions. He goes on, we do not rigorously know that PCI is the right thing to do in unstable lesions, and we do not know how to identify them reliably, but there are hints. This should be addressed in multi-center trials. So my objection is not against the primary argument that I made. I object to the blanket discussion of full revasc and ACS. There are nuances, and I know that you pursue objectivity, and I've often heard you say, not so fast, there are nuances. And this is one such area, in my opinion. Now, my rebuttal to Adrian in Wells is that his argument does make sense. I do not do PCI. All I can do is read the trials. But from being an interventional electrophysiologist, I understand that trials may not represent every scenario we come across. Trials give us an average effect size for patients similar to those in a trial. That said, though, anytime we think a scenario that we're involved with is outside a trial, it's kind of on us and our profession to study that specific scenario to prove that what we're doing is correct. All right, I received a third email on iModern, and this one was more in support of my view. I won't go into the details because this person sent it as a letter to the New England Journal of Medicine in hopes that NEJM will publish it. Suffice to say that if you were to analyze the iModern data in a non-frequentist way, the probability of a large benefit or the probability of a large harm would be quite low. You just look at the 95% confidence intervals, and the probability of no difference would be high. And if there's no difference in full revasc versus culprit only, then obviously you favor doing fewer PCIs and stents. All right, the next topic is huge news, perhaps the biggest news of the year, really. And it's just a few hours old. It was presented this morning at 11:30 a.m. The American Society of Nephrology met this weekend, and there was a major study presented. It's published in New England Journal of Medicine, and it's called the PISCES trial, like fish, PISCES. This was a cardiovascular outcomes trial. A group of investigators led by the University of Toronto presented very positive results of this trial of high-dose fish oil supplementation in patients with end-stage renal disease on hemodialysis. And again, this is important because heart disease is the leading cause of death in patients who are on dialysis. Now, the wild thing is that fish oil supplementation is highly controversial in the general population of patients. Now, we have the Reduce It trial showing that icosapent ethyl looks really positive, but the hook there is that the mineral oil placebo may have been harmful to patients in the placebo arm. And then you have the Strength trial of a DHA-EPA combination having no effect. So Reduce It was in New England, Strength trial is in JAMA, and I'll link to those. So our priors here, would fish oil be beneficial to patients on dialysis? We'd have to be quite pessimistic about this. Because A, fish oil supplementation is not clearly beneficial overall to anyone, and B, it's hard to show benefit of anything in patients with CKD on dialysis. Statins, for instance, have clear benefits in the general population but do not lower CV outcomes in end-stage renal disease. Neither does MRA drugs. Now, the thing about patients on dialysis is that they often have lower levels of omega-3 fatty acids compared to people in the general population. So there is that. So PISCES, what was PISCES? PISCES studied citrus-flavored omega-3 polyunsaturated fatty acids in 4 1-gram capsules containing a total of 1.6 grams of EPA and 0.8 grams of DHA, versus the citrus-flavored corn oil placebo. The primary endpoint was a composite of all serious cardiovascular events. This includes sudden and non-sudden cardiac death, fatal and non-fatal MI, peripheral vascular disease leading to amputation, and fatal and non-fatal stroke. The trial took a long time to finish. It began in 2013, finished recruiting in 2019. There were just over 1,200 patients randomized. The average follow-up was 3.5 years, and patients were 64 years old, about 40% female, and 2/3 had known cardiovascular disease. Here are the results. The rate of serious cardiovascular events was significantly lower in the fish oil group than in the placebo group. It was presented as 0.31 versus 0.61 per 1,000 patient days. That's a hazard ratio of 0.57 and 95% confidence intervals of 0.47 to 0.70. That p-value was highly, highly significant. Now, the trial actually reports actual percentages of patients experience at least one event, and this maybe is easier to digest. The fish oil group had 20.8%, and the placebo group had 33.7%. So that's a 12.9% absolute risk reduction in an NNT of 8. And get this is, I think, the most critical thing. Every component of the primary endpoint was statistically lower in the fish oil arm. CV death, 45% lower. MI, 44% lower. Peripheral vascular disease, 43% lower. And stroke, 63% lower. The Kaplan-Meier curves show benefits starting to occur after 6 months, and then the benefits, the separation, continue to increase over time. There were no serious adverse events. Okay, what are my comments on this? Whenever you have such strong data, it's important to be skeptical. Now, on the one hand, you could say it's been hard to show that normal interventions such as statins and MRAs and ICDs, they don't work in patients on dialysis. So why would fish oil work? What's more, it's not even a sure bet that fish oil works in the general population. Now we have a situation where there are huge benefits, both clinically meaningful effect sizes and statistically robust. So we have to posit there's a clear heterogeneous treatment effect where patients on dialysis benefit more. Now, how should we handle a situation when our priors are so pessimistic, but the data is extremely persuasive? This is akin to seeing a massively positive stress test in a very low-risk patient with atypical chest pain. Well, one way to consider this is to look back at other trials. Now, I didn't know about this, but reading the discussion of this paper, the authors tell us that there was a trial called the FISH trial, which is kind of funny. It was published in JAMA 2012, and this was a fish oil versus placebo trial for graft patency in dialysis patients. And the fish oil did reduce graft thrombosis, but it did not quite reach statistical significance, so it sits in JAMA as a negative fish oil trial. However, a secondary outcome of cardiovascular events indeed was 57% lower in the fish supplement arm. Now, you could also posit that end-stage renal disease patients have very low levels of omega-3 fatty acids, and supplementing them may work just by repleting an important element. But in the end, my take here is that the strength of this data can overcome the negative priors. Yes, of course, we would like to have a confirmatory trial. That would be great. But PISCES took more than a decade to finish. So what do we do over the next 10 years waiting for a confirmatory trial? My take is that given the lack of adverse effects and the fact that fish oil, is probably not super expensive, we ought to begin using these agents in patients on hemodialysis. All right, next topic is a bunch of news in the obesity world. And the first isn't even medical news. The first is a White House press conference. In the Oval Office yesterday, the Trump administration announced a deal struck with drug makers Eli Lilly and Novo Nordisk to offer their GLP-1 drugs at steep discounts for certain Medicare and Medicaid patients. This deal also includes lower prices for GLP-1 drugs for Americans who can use cash to buy them through a new government website, which is expected to be debuted next year. This will allow people to just buy drugs directly from the companies. For Medicare and Medicaid, semaglutide and tirzepatide will cost the insurance programs about $245 a month, and then Americans on Medicare will only be responsible for a $50 copay. This is at least what the White House said. For oral versions of the drug, which of course first need to face FDA approval, the price could be as low as $149 per month for Medicare and Medicaid. Now, Novo Nordisk asked the FDA to approve an oral version of semaglutide this year, and Eli Lilly plans to submit an application for its weight loss pill candidate to the agency by the end of the year. And then there will be a direct-to-consumer site where patients will pay lower but still pretty high prices for the drugs. And I say this could be a huge deal because right now, patients with obesity, in the U.S. at least, really can't get these drugs covered unless they have diabetes, established heart disease, or sleep apnea, which are the FDA-labeled indications. And I say it could be a huge deal, could be, because this is just an announcement and putting into action is yet another thing. But think about it. Expanding access to GLP drugs might have a direct impact on EP, electrophysiology, because so many of our patients with atrial fibrillation have obesity. And we know that weight loss is beneficial for these patients. So there are many, many times when I see a patient in the office with AFib and obesity, and I want to use the GLP drugs, but the patient doesn't have diabetes or doesn't have cardiovascular atherosclerotic disease, and so there's not an indication. And so I think this is good news. The second piece of obesity news is that The Lancet has published a phase 2 trial of a new drug class. This is a selective amylin receptor agonist. I surely will mispronounce this new drug called Eloralintide, which is delivered via subcutaneous weekly injections. Now, the weight loss was dose-dependent and up to 20% in higher doses. And unlike the GLP-1 agonist, heart rate decreased, not increased. There were also reductions of all metabolic measures such as hemoglobin A1C, lipids, and CRP. There were also lower rates of GI adverse events when compared to rates in the GLP-1 trials. Now, I did not know this, but there's actually already an amylin agonist approved, and it's called PRIMULTI, and is used as an adjunct to mealtime insulin for the treatment of patients with type 1 and type 2 diabetes. Now, clinical studies in people with and without type 2 diabetes showed modest weight loss, although PRIMULTI has not been approved for weight management. So my comments here, I don't think there's much to say other than this seems promising. I mean, it could be a replacement for people who can't take GLP-1 drugs. The next step, of course, is you have to show outcomes are better. Weight loss is a surrogate, right? What we want to know is does the amylin agonist also reduce cardiovascular outcomes in patients with diabetes and with cardiovascular disease? And of course, you also want to know about safety in phase 3 studies. That much weight loss in patients with obesity, though, is surely encouraging, as is the fact that heart rate is decreased rather than increased. And the third piece of news has to deal with a class effect of GLP-1 agonist. So the European Heart Journal Open has published a post hoc analysis of the SURMOUNT-5 trial. And SURMOUNT-5 compared tirzepatide with semaglutide in patients without diabetes. New England published the original trial in May, and it found that tirzepatide was superior to semaglutide for weight loss. You saw about 20% reduction with tirzepatide versus 14% for semaglutide. So this most recent analysis, led by Professor Mamas, the famous Mamas, compared the change in predicted 10-year cardiovascular risk between the two therapies. Now, the impact of cardiovascular risk reduction was then estimated as the projection of preventable cardiovascular events over 10 years for the two drugs in a USA population. Now, here's how I understand this analysis. They first excluded patients with established disease. They then estimated a 10-year cardiovascular disease risk score, and this was using BMI-based sex-specific risk equations. They cited the study where this risk equation was used, and these were developed from the sort of Framingham Heart Study. So this model and the equation uses sex, age, BMI, blood pressure, treatment for hypertension, smoking, and diabetes, and it sounds it's a lot like the pooled cohort equation. So they then graph the reduction in predicted risk based on the measures in the SURMOUNT-5 trial. And they found that tirzepatide results in greater reductions in predicted cardiovascular risk, at each time point in the trial. They then apply these risk reductions to NHANES data, NHANES being a longitudinal study of U.S. adults, and they find that if all the eligible population received treatment with these two drugs, an estimated 2 million cardiovascular events could be potentially prevented with tirzepatide over 10 years compared with 1.15 million with semaglutide. Now, this post hoc analysis, has got a lot of attention online, but I don't love the analysis, really. First, it's funded by Lilly, the makers of tirzepatide, and all it does is simply plugs the greater reductions in weight with tirzepatide into equations and finds that predicted risk will be better with tirzepatide. And if applied to huge populations, there'll be nearly 1 million fewer cardiac events if we used tirzepatide over semaglutide. It almost looks like marketing for tirzepatide. And I don't really think this is the way to properly compare the drugs with predicted risk. The way to compare them is to do a SURMOUNT-5 with enough patients to measure outcome data. These equations are fraught with issues. In the real world, semaglutide might perform better. You don't know. There may be less weight loss, but there may be other effects besides weight loss. Not only that, semaglutide already has proven benefits as a cardiovascular disease modifying agent in the SELECT trial. Semaglutide also has proven benefits in patients with diabetes. Now, I think that tirzepatide is likely to have similar benefits, or even maybe greater benefits. But without trials that measure outcomes, it's just an assumption. We accept that many drugs have a class effect, like statins, ACE inhibitors, SGLT2 drugs. They all have a class effect. But we accept the class effect not because of predictions from equations, but because there's actually outcomes trials with the different drugs showing that they all reduce cardiovascular outcomes. So let's just wait for comparison trials before concluding which GLP-1 drug is better. All right, speaking of problematic studies, there's been a problematic study in stroke care that's made the rounds on social media. It's JAMA Internal Medicine has published the LAMP trial, LAMP. This is liraglutide in acute minor stroke or high-risk TIA patients who also have diabetes. The idea is that patients with diabetes have an increased risk of stroke. Minor acute strokes and TIAs can be sort of harbinger of bigger strokes. GLP-1 drugs have proven benefit in patients with diabetes. So, could GLP-1 drugs reduce the rate of recurrent stroke after a small stroke event? The LAMP trial was conducted in China. 636 patients were randomized within 24 hours of stroke symptoms to liraglutide or usual care. Note that, usual care. No placebo was given. The trial was terminated early for funding and low enrollment issues. The results were amazing. Amazing, my friends. Within 90 days, 7.9 patients in the liraglutide group versus 13.8% in the control group experienced stroke recurrence. That's a hazard ratio of 0.56 with confidence intervals going from 0.34 to 0.91. The p-value is 0.02. A significantly higher proportion of patients had a modified ranking score less than equal to 1, which is a good outcome. This was 87% liraglutide, 78% control arm, and that was statistically significant. Now here's the thing, that when you look at the Kaplan-Meier curves, they show separation within a day or 2 or 3 of liraglutide, and that separation continues on. So my comments, I think there's some good critical appraisal lessons here. One lesson is that the results seem too amazing. A nearly halving of recurrent stroke and absolute risk reduction of nearly 6% is massive, but the p-value barely makes significant at 0.02. This tells you that the results are fragile. What's more, I have trouble explaining the early separation of the events. How does a GLP-1 drug prevent recurrent stroke that fast? Now, the trial was open label. This is another point. So one group knows they got an injection of something, the other group gets no injection. That to me is a much weaker design than a proper placebo. Though it's common in structural cardiology, and here I'm winking at the tricuspid valve structural intervention people. Early termination of the trial also has the effect of accentuating effect sizes. So in sum, this finding is unlikely to be replicated. And I am sort of torn if there is even enough here to spend the money on a confirmatory trial. I sort of doubt it, but some online felt like it could be an interesting finding and we should repeat it. But I'm just not sure. I mean, trials cost a lot of money, it's expensive and time-consuming, and I'm just not sure that GLP-1s are going to have a hugely positive effect in minor stroke. All right, next topic is an AHA preview. The American Heart Association meeting is happening this weekend in New Orleans. I wrote a preview column of some big trials, and indeed there are going to be some important trials. One is the ADAPT-AF DES. This is similar to Aquatic trial, which found that oral anticoagulation alone was superior to oral anticoagulation plus low-dose aspirin in patients who have both CAD and AFib. So ADAPT is a South Korean trial studying oral anticoagulation plus clopidogrel versus oral anticoagulation alone. And it'll be interesting to see if that is similar to Aquatic and whether we just move to oral anticoagulation alone for patients who have had a distant stent and AFib. Now, another trial is the OCEAN trial. OCEAN is an RCT of stopping versus continuing anticoagulation after a successful AF ablation. I really look forward to the results of this one because I think we overtreat many patients who've had no AFib after their ablation. A third trial is the CLOSURE AF trial. This is an RCT of left atrial appendage occlusion versus best medical care in patients with AF who have a high risk for stroke and bleeding. My worry here is power. There's only 912 patients randomized, and it's a non-inferiority endpoint with events expected to go in different directions. And I know this sounds technical, but it's not. It's important. The problem here is when you have thrombotic events go down with oral anticoagulation and bleeding events go up with oral anticoagulation, you make non-inferiority easier to reach. In other words, you have efficacy endpoints going in an opposite direction as safety endpoints. And remember that non-inferiority, no difference is the positive outcome. And so if they cancel each other out, you can declare something non-inferior, but it's not the proper way to do it. The proper way to do non-inferiority is like they did in the DOAC versus warfarin trials. You show non-inferiority for efficacy, and then you show superiority of safety. So we shall see the results in this. And the fourth biggie, I think, at AHA is a trial called Vesalius. This is 12,000 patients without heart disease given evolocumab on top of statin use. Recall that the original PCSK9 trials were really secondary prevention trials. The question, I think, is how well PCSK9 drugs perform as primary prevention in these lower risk patients. I think the question here won't likely be whether the drug works. I suspect it does. It will be the effect size relative to cost. You'd also want to know whether there's a real difference in death or CV death, because the way MI is going in the modern era, that is, it's so much easier to get diagnosed with MI, you could have a reduction in MI, and if it's without a reduction in cardiovascular death, I'm not sure it's that substantial. Now, a couple of trials that I missed in my AHA preview that's online and you can read, and I will link to it. One fun one is going to be the sham PFA trial. It's Monday, featured science, PFA ablation versus a sham ablation, and I can't wait to see what happens. And I just want to say that I think there is a placebo-resistant effect with AFib ablation, but it should be tested. And also on Sunday, we hear the results of the meta-analysis of the modern beta blocker trials: Reboot, Reduce AMI, Beta-AMI, Dan Block, and Capital RCT. Remember that at the ESC meeting just a couple months ago, the meta-analysis was only in patients with mildly impaired EF. The vast majority of patients in these RCTs had preserved ejection fraction. And I've previously predicted in my writing that the combination of these trials will likely show no significant benefits to beta blockers. And if that happens, I hope we can change guidelines, because right now we're compelled to give beta blockers post-MI in patients with normal EF, and I don't like to have to give non-beneficial drugs. And as soon as the guidelines change, then the quality measures need to change, and we need to be not compelled to use beta blockers in all patients with MI. That doesn't mean that there might be patients who might benefit from beta blockers, but right now we're compelled to give it in all patients, and I predict that this meta-analysis will show no significant benefits. In fact, I've already said that. And finally, the beta blocker post-MI story is a really good story to look into, because it's a classic example of how seminal trials should have expiration dates, because beta blockers were once very beneficial after MIs back in the era before revascularization. And now MIs are totally changed with acute PCI. We have a similar thing with ICDs, where ICDs were clearly beneficial in heart failure, but now modern heart failure therapy has changed, and we need further data to confirm that there's actually still an ICD benefit. Okay, that's it for this week in cardiology. Remember to tune in next week, as I'll have a ton of studies to talk about coming from the American Heart Association. As always, if you like this podcast, take the time, give us a rating, write me a review. And if you don't agree with something I said, like the listeners today, please do write me. I really appreciate that. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.